Myocardial infarction, commonly known as a heart attack, is the death of cardiac muscle tissue due to a lack of blood supply, a condition called ischemia. In industrialized countries, myocardial infarction accounts for 10–25% of all deaths, making it a leading cause of mortality. The risk factors are closely tied to atherosclerosis and include diabetes, hypertension, smoking, and high cholesterol. The incidence is higher in men than women, but rises in women after menopause. Notably, hormone replacement therapy does not offer protection. As people age, the frequency of heart attacks increases. Other contributing factors include hypertrophy of the heart without a corresponding increase in coronary blood flow, increased myocardial demand during exercise or emotional stress, and diminished coronary blood flow due to coronary artery disease or shock. Understanding these basics sets the stage for exploring how a heart attack develops and its consequences. The development of a heart attack involves a complex interplay of factors. It often starts with myocardial ischemia, where the heart muscle doesn't get enough oxygen. This can be due to sudden blockage from a ruptured plaque, platelet aggregation, or less commonly non-atherosclerotic causes like vasospasm or emboli. Within seconds of ischemia, aerobic respiration in heart cells ceases, leading to a rapid loss of ATP, accumulation of lactic acid, and depletion of glycogen. Within 60 seconds to 2 minutes, the heart loses its ability to contract properly, which can cause heart failure even before tissue death occurs. If the lack of blood flow persists, irreversible injury and cell death begin after about 30 minutes, becoming complete by 6 hours. The damage typically starts in the subendocardium and can progress to involve the full thickness of the heart wall, especially if the blockage is severe and prolonged. These changes set the stage for the visible and microscopic alterations seen in heart tissue after an infarct. The physical changes in heart tissue after a myocardial infarction can be observed both grossly and microscopically. In the first 12 hours there may be no visible changes, but by 12–24 hours the affected area appears as a red-blue hue due to trapped blood. Over the next few days the center becomes soft with hyperemic borders, and by 10–15 days, a soft yellow area surrounded by a red rim of granulation tissue develops. Eventually, after more than 15 days, the area is replaced by a thin gray-white fibrous scar. The most common sites of infarction are the left anterior descending artery LAD, which affects the interior wall of the left ventricle and the septum, and the right coronary artery RCA, which impacts the inferior and posterior walls. The left circumflex artery LCX is less commonly involved. These patterns help clinicians determine the likely artery involved and guide treatment decisions. Diagnosing a myocardial infarction relies on a combination of clinical symptoms, ECG changes, and laboratory findings. The World Health Organization requires at least 2 of the following: prolonged ischemic chest pain, serial ECG changes, or a rise and fall in serum cardiac markers. ECG findings may include ST segment elevation, deep Q waves, or T wave inversion. Blood tests for cardiac markers are crucial. Troponins CTNT and CTNI are highly specific and sensitive, rising within 2–4 hours and remaining elevated for up to 14 days. Creatine kinase MB (CKMB) also rises early but is less specific. Other markers like myoglobin and LDH are less specific but can aid in diagnosis. The combination of these findings helps clinicians confirm the diagnosis and assess the severity of the infarct, guiding further management. Heart attack can lead to a range of serious complications. Arrhythmias, heart failure, cardiogenic shock, and mechanical complications like ventricular rupture or aneurysm are common. Dressler's syndrome, a type of post-infarction pericarditis, can occur weeks after the event. The risk of sudden cardiac death is highest within the first hour, often due to fatal arrhythmias. Long-term prognosis depends on the extent of ventricular damage and the degree of coronary artery obstruction. Poor prognostic factors include advanced age, female gender, diabetes, and previous heart attacks. Chronic ischemic heart disease may develop, leading to progressive heart failure. Ultimately, understanding these risks highlights the importance of early intervention and ongoing management to improve outcomes for patients who have suffered a myocardial infarction.